Welcome everybody. This is a chest x-ray on an adult patient with the aim of showing 3 quick things for junior followers. The first thing we see is this line that curves and goes all the way down to reach the hilar area. This is called an accessory azygous fissure. Compare the appearance of this fissure to the normal horizontal fissure you have on the right. They look very similar. This is a common extra fissure that you could see in many patients, and it results from an azygous that develops at the apex and descends all the way down to assume its normal location. The azygous is classically located here at the right tracheobronchial angle. So as the azygous descends from above, it invaginates the lung and the associated covering pleura, and that what creates the accessory fissure. If you notice this area of what appears as fissural thickening, this is in fact the azygous vein. As the azygous vein descends and pulls the pleura with it, it might stop at any location along this path. So if you noticed the accessory azygous fissure, this opacity here would not fool you for an abnormal nodule. The other thing I want to show to juniors is this additional line that you see here above the clavicle. This line is also seen on the left side, and it appears as a line that has soft tissue density and parallels the upper edge of the clavicle. Although this line is not seen in most patients, it's very commonly seen. It is called a companion shadow. Given that you see a normal clavicle with normal cortex here, and that this is soft tissue in density, do not confuse this for periosteal reaction. This companion shadow is basically a result of the way the X-ray beam hits the soft tissue overlying the clavicle. The other reason I show you this, it's a common question in reading sessions and in MCQs. Now let's go to the third finding. Did you see it yet? We agreed from previous sessions that the density behind the heart should be assessed very carefully, since the retrocardiac region on X-ray is a hidden area. Looking carefully at the region of the left cardiac shadow, you notice that you have this additional density. The finding has a very high density, which could either be due to calcium or metallic components, and it has this tubular wavy appearance. When you see a tubular wavy appearance, that's something that could be described as serpentine, which means looks like a snake. And most of the time when you're talking about serpentine abnormalities, you're talking about vessels, since they look like that. And since we suspected that this could be metallic, in this location within the heart, this is actually a coronary arterial stent. This is the lateral chest X-ray on the same patient, and you could see the stent in a better way here. Here's a close-up of that stent, and you see how it has this tubular course that extends over the expected location of a coronary artery. So let's summarize what we have learned today. First, there is an accessory azygous fissure, which is a normal variant that is commonly seen. Since it results from invagination of the azygous vein as it descends from the apex all the way down, you could see the azygous vein itself at different levels. Do not confuse the azygous opacity for a nodule. The second thing we learned is that you have this additional shadow that commonly parallels the clavicle, known as the companion shadow, and this is not a periosteal reaction. And finally, we emphasize that you have to look carefully at the cardiac region, and now you know the appearance of a coronary arterial stent. You've also learned a neat term known as serpentine, something that could make you look good in front of your colleagues. Before I end this case, I would like to take the chance to thank all the people who joined us in the webinar last week. That webinar, despite some technical difficulties, was a success because of your presence. This concludes today's case. Thank you for watching. Your comments are appreciated as usual, and see you with more cases later. This is an 82-year-old male patient who presented with abdominal pain and distension. This presentation was a few days after undergoing transurethral resection of the prostate. And this acute presentation developed while the patient was in hospital after the procedure. There are several findings, such as the bilateral pleural effusions and the associated compressive basilar atelectasis of the lungs, also as the presence of ascites and the nonspecific dilatation of some of the bowel loops. The reason I'm showing the case is to concentrate on this abnormal finding here. Note that the examination was performed without administration of intravenous contrast, but oral contrast was given. That's why you see contrast going through the esophagus into the stomach. So this bright area here is oral contrast within the stomach. As we proceed from the gastric fundus into the gastric body, you'll reach all the way to the distal stomach. So as you go distally, you reach the pyloric antrum and then the pylorus into the first part of the duodenum. You'll notice that this abnormal collection has a fluid level. So this is air and this is contrast. It's located between the stomach and the retroperitoneal pancreas here. And most importantly, it has this linear-like communication with this part of the duodenum, the first part of the duodenum. Let's do this again. You see the esophagus, gastroesophageal junction, stomach. You go all the way to the distal stomach, reach to the duodenum, and then you see this communication here. So this is the linear leakage of contrast from the first part of the duodenum into this space behind the stomach and anterior to the pancreas. Putting everything together, you have a clear-cut sign of perforation of the first part of the duodenum with a collection behind the stomach here. It's not surprising to have perforations with localized collections and absent large amount of free air. So don't expect a large amount of free air with all of these perforations. However, have you noticed the small amount that's localized here? This case was easy since we gave oral contrast that clearly showed the leakage through the first part of the duodenum, but this is also a good sign to look for. So this was a case of duodenal ulcer perforation that's detected on CT without contrast, only with oral contrast. To finish this quick case, let me show you the follow-up. And what's interesting is that this patient was treated in the radiology department. The patient was considered a high-risk patient due to multiple comorbidities, and the elected procedure was to drain this collection. And as you see here, this is a drain that was inserted under CT guidance in radiology, and the collection that we just described has disappeared. So that's it for today's case, which shows you a bit of the diagnostic and therapeutic capability of a radiologist. Thanks for watching, and see you with more cases later. This is a frontal chest radiograph on a 67-year-old female patient who presented with dysphagia. And this is the lateral chest x-ray on the same patient. There are several findings on this chest radiograph. First, there is hyperinflation of both lungs, as denoted by increased rib counts above the diaphragm. Add to that you have increased lung lucency in what we used to call simplification of the lungs. Since the increased darkness makes the vessels more pronounced and even apparently less in number, the term simplification was used. If you add to that there is flattening of the hemidiaphragm that's clearly seen on the lateral x-ray as well, the constellation of findings are consistent with emphysema, and on questioning, the patient was a heavy smoker. Another finding is the presence of these linear opacities in the lower lungs, more pronounced on the right side. So see how you have these linear densities that are more than expected. These are consistent with interstitial opacities. some of which are tubular and others which are rounded, an appearance that is fitting well with bronchial wall thickening. This finding by itself is nonspecific and could be a representation of chronic bronchitis of smoking. However, with chronic bronchitis and respiratory bronchiolitis of smoking, you'd expect the appearance to be at least more diffuse or upper lung predominant. Since the abnormality is seen more in the lower lungs, you might think about aspiration, since aspiration is gravitation dependent. Again, aspiration in a standing or sitting patient would go to the gravity-dependent regions, and that's the lower lungs. Another finding is blunting of the right costophrenic angle, which is consistent with the pleural effusion, clearly seen on the lateral as well. Although all these findings are important to mention, this is not the reason I'm showing you the case. Have you seen the abnormality yet? On the lateral radiograph, you see the cardiac shadow, and you see this here as the aortic arch. This is the aortic arch border. Again, cardiac shadow and aortic arch. Now that you have seen that, there is an additional abnormality that you should not allow for, which is this line here. This line is not related to the density of the aortic arch. It's on top of the aortic arch. As a general rule in radiology, we do not like to see straight lines. When you see a straight line, that means that this area contains fluid and air. And this is what we call an air fluid level. There are a few reasons you might have an air fluid level within the lungs, but if you think about the location, this is the trachea. And what lives behind the trachea, a structure that you don't usually see on chest x-rays, is the esophagus. Now the case is starting to make more sense. This is the trachea here, and this is a dilated esophagus with a fluid level. A question for more senior followers. Have you seen this on the frontal radiograph? It's there, but it's a tough pickup. On the lateral x-ray, the fluid level resides immediately above the superior border of the aortic arch. It also projects over the same level of this vertebral body, in particular the superior end plate of this body. Now this is the superior border of the aorta, and the fluid level is here, but it's very tough to pick up because it's projecting over the bones. It almost simulates the superior end plate of the vertebral body located here. This tells you how valuable a lateral chest x-ray is. There are many reasons why you'd have a dilated esophagus with a fluid level, one of which you have to exclude in older patient would be esophageal cancer. This is the axial CT on the same patient showing the trachea anteriorly and the dilated esophagus posteriorly with an air contrast level. So an air contrast level because we gave the patient oral contrast, and notice how the esophagus is dilated all the way till you reach here. You start to lose the lumen. So this is the narrowed lumen, and this entire soft tissue density is a very thickened esophagus. As you go lower down, the abnormality obliterates the lumen. And the more distal esophagus, reaching to the stomach here, distal to the lesion, is actually collapsed. This is the coronal image, and this is your trachea. As you go posteriorly, you see a dilated esophagus containing an air contrast level here. And all the way down, you have this abnormal mass-like thickening of the esophagus, which is leading to proximal dilatation and distal collapse. The same thing is seen on the lateral CT, where you have the trachea, the esophagus behind it, distended with a fluid level, and this mid to lower esophageal abnormality, which is actually consistent with esophageal cancer. So let's summarize what we learned today. Knowing what we know, everything now makes sense on the chest x-ray. From the chest x-ray, we knew that hyperinflation, increased lucency, simplification of the lung, and flattening of the diaphragm are signs of emphysema. And by that, we knew the patient is a smoker. We also knew that the patient has a small right pleural effusion seen on both frontal and lateral. And the most important teaching point is to look for fluid levels. They are not normal. They denote that that space contains air and fluid. We also learned that some abnormalities are difficult to see on one view, and that's why a lateral chest radiograph is very useful. A major consideration for a fluid level behind the trachea is that of a dilated esophagus. With a dilated esophagus, one of the differential diagnostic possibilities would be that of an obstructive lesion in an adult. Make sure it's not esophageal cancer. And now it even makes more sense that we saw these interstitial opacities suspected to be bronchial wall thickening from aspiration. So the patient developed aspirations as a result of esophageal obstruction. If there is one take-home point from this case, be very careful with fluid levels. Thanks for watching. Your comments are always welcomed, and see you with more cases next week.